Hi, my name is Dr. Katie Montelione. I am a general surgery resident at Cleveland Clinic Foundation in the Center for Abdominal Core Health. Today, I will be discussing the systematic approach to repairing flank hernias taken by surgeons at our institution. The authors have no disclosures. Flank hernias are uncommon and challenging surgical problems that occur as a result of varied etiologies, including congenital defects, trauma, and incisions off the midline, particularly those used for retroperitoneal access. They can occur around a patient's entire side, from the edge of the rectus to the lumbar spine, at the level 3 centimeters above and below the umbilicus, as defined by the European Hernia Society. They can also occur with or without a midline component. They require special consideration of fixed bony landmarks and neurovascular structures. Furthermore, there are few case series and thus numerous unanswered questions regarding the optimal way to repair flank hernias. In order to answer some of these questions, we identified variables that we could measure objectively in the preoperative setting to help categorize the flank hernias that we encounter. These variables were the width of the defect, the presence or absence of an associated midline hernia, and the distance of the defect from the midline. We also identified specific operative decisions that could also be described objectively: MIS versus open approach, patient positioning on the operating room table, and incision location. Our institution is a quaternary center with a high volume of flank hernia repairs and surgeons who routinely collect prospective data on their hernia repairs. These factors make us well suited to identify a large cohort of patients who have undergone flank hernia repair. We asked, how do surgeons at our center approach flank hernia repair? We then generated an algorithm using the variables we identified to describe their practices. This was a hypothesis-generating study, which will require subsequent validation of the algorithm that we propose. Our data were obtained by retrospective review of prospectively collected data from the Abdominal Core Health Quality Collaborative Registry and from our electronic medical record. We included all patients from our center who underwent elective flank hernia repair over the prior 5 years. All patients had L2 hernia defects, preoperative CT scans, and had completed 30-day follow-up within ACHQC. Preoperative CT scans were reviewed to determine the distance between the midline and the medial fascial edge of the hernia, as demonstrated on these representative images. In total, 112 patients were identified. Our cohort had a broad age distribution with a median of 59.5 years and included roughly equal numbers of male and female subjects. The patients were medically complex with BMI ranging from normal to obese, including 6% with BMI greater than 40, and approximately 3/4 were classified as ASA Class 2 and greater. The hernia defects were predominantly grade 2. 30% had undergone prior hernia repairs, including 13% with 2 or more prior hernia repairs, and 5% with prior component separation. 76% underwent open repair, 17% underwent MIS repair, and 7% underwent lap-assisted repair. 73% of the patients were positioned supine, and 27% in lateral decubitus. 40% of the open hernia repairs were performed through a midline incision, 32% were repaired through a flank incision, and 4% through a subcostal incision. 7 patients undergoing open repair required more than 1 incision. Roughly half had a midline component, and we saw a large range in hernia width and in distance of the defect from the midline. Our patients had diverse etiologies of flank hernias. The majority, nearly 40%, were related to liver and kidney transplant or resection and subcostal incisions from pancreatobiliary procedures. We also saw numerous flank hernias related to prior colorectal surgery, which may be due in part to the high volume of colorectal surgery at our center. As expected, we saw hernias related to retroperitoneal or spine axis, trauma, and congenital defects. For flank hernias without an associated midline component, nearly 40% resulted from a kidney transplant or resection. An additional 9% resulted from liver procedures, colorectal procedures, and trauma, respectively. First, we analyzed which operative approach was chosen relative to the width of the hernia defect, as measured on preoperative CT. While hernias of almost any width were repaired through an open incision, MIS and laparoscopic approaches were nearly always reserved for defects less than 10 centimeters in width. We next looked at patient positioning. If a hernia had a midline component, patients were always positioned supine. This allows surgeons to ensure adequate mesh coverage to the patient's contralateral side. For hernias without a midline component, roughly half were positioned supine. Lateral decubitus was preferred when the distance between the midline and the medial edge of the defect exceeded 12 centimeters. Similarly, hernias with a midline component were nearly always repaired through a midline incision. A few required an additional counter incision over the hernia defect. Hernias without a midline component were nearly always repaired through a single flank or subcostal incision overlying the defect. As expected from a cohort with complex hernias and frequent comorbidities, many patients developed complications in the 30-day postoperative window. The majority were surgical site occurrences or infections, which were managed with antibiotics and/or percutaneous drainage. There were very few major complications, and only one instance of early recurrence requiring reoperation. Based on these data, we developed the following algorithm to describe the approaches taken by the surgeons at our center. We reserve MIS approaches for hernia defects less than 10 centimeters wide. When hernia width exceeds 10 centimeters, we take an open approach. When there is a midline component, the patient is positioned supine and the hernia approached through a midline incision with or without a counter incision. When there is no midline component, we use preoperative CT scans to measure the distance to the medial fascial edge of the hernia. If the defect is less than 12 centimeters from the midline, the patient is positioned supine and the incision is made either midline or over the defect. And if the defect is more than 12 centimeters from the midline, the patient is placed in lateral decubitus after induction of anesthesia, and we make a flank incision. Patients who do not fall into one of the proposed categories are approached on a case-by-case basis after considering the operative history and the position that will optimize access to the most difficult area of the repair. Going forward, we would like to further validate this algorithm with data on long-term outcomes. Thank you for your time.